Bienvenidos a esta última sesión del Webinario Internacional de Educación Continua en Vía Aérea del Programa de Anestesiología y Reanimación de la Universidad Diego Portales. Les recuerdo que el Programa de Anestesiología y Reanimación de la Universidad Diego Portales es dirigido por el doctor Ricardo Latropa Allende, y este programa tiene por objeto formar un especialista capaz de ejercer la anestesiología en forma integral, entregando al paciente una atención acorde con la evolución de la especialidad, adaptándose a los cambios epidemiológicos y al desarrollo de la tecnología. Ustedes pueden obtener más información acerca del programa solamente escaneando el código QR que ustedes tienen en su pantalla. Este webinario tiene el apoyo de la Sociedad Europea de Vía Aérea, EAMS, y también de la Sociedad Española de Anestesiología, Reanimación y Terapéutica del Dolor, de España. La EAMS es una...
Nunca me conecté hasta hace 2 años que vienen mandando webinar, pero hasta ahora yo tengo inglés habitualmente. Entonces no... ¿Qué le pasó a esto?
Hay un... Ya. La EAMS es una sociedad multinacional que agrupa a todos los países de Europa y tiene una sociedad amiga, que es la sociedad inglesa, la DAS, y también la sociedad americana, que es la SAM. En Latinoamérica, la EAMS tiene representaciones en Argentina y en Chile. En Argentina, la doctora Paula Chiesa la lidera, y en Chile tengo el honor de poder compartir esta actividad con un excelente grupo de anestesiólogos y de otras especialidades compatriotas en este amor por la vía aérea. Los invito a unirse a la EAMS. En nuestros países latinoamericanos tienen un descuento especial de alrededor del 50% de la membresía anual, y expresado en dólares son alrededor de $30 al año. Esto da derecho a los miembros a la suscripción online a la revista Trends in Anesthesia and Critical Care, tienen acceso preferencial a contactar speakers de renombre mundial, como el doctor Huitink, que les presentaré en un instante más, investigaciones colaborativas en vía aérea, red de residentes, posibilidad de formar un council, como les acabo de decir, una representación de sus países ante la EAMS, descuentos en inscripción a eventos científicos, y también recibir el artículo del mes seleccionado por expertos de la EAMS. Y eso les puede servir para poder implementar muy entretenidas reuniones clínicas en sus servicios. Ahí en el código QR ustedes pueden acceder al sitio web para hacerse miembros. Este año 2022 hemos tenido una constelación de estrellas, expertos en vía aérea, que nos han dado un bagaje de conocimientos y de experiencias personales, diferentes temas relacionados con el manejo de la vía aérea. Hemos tenido especialistas de Argentina, del Reino Unido, de Australia, de Estados Unidos, de Brasil, de México, Colombia, de Italia, y por supuesto el doctor Carlos Reyes desde Chile. Les quiero dar las gracias a todos ellos por el tremendo aporte que han hecho a la comunidad latinoamericana en mejorar los conocimientos acerca del manejo de la vía aérea, para lograr un nivel de calidad y seguridad que sea digno de nuestros pacientes. Contamos con el muy valioso servicio de traducciones remotas, que ustedes van a poder acceder a la traducción del inglés con el canal de interpretación.
Vamos a ponerle entonces un gramo hacia un examen.
¿El micrófono está abierto? Ok. Así que los invito a participar también, ya sea pidiendo la palabra con la herramienta de levantar la mano que ustedes tienen en el fondo en la parte baja de su pantalla, o también escribiendo preguntas o comentarios en el chat. En este momento quiero presentarles al doctor Johannes Huitink. Él es un anestesiólogo holandés formado en el Centro Médico Académico de Ámsterdam, obtuvo un doctorado en filosofía en la Universidad Brige, no sé si se pronuncia bien así, de Ámsterdam. Su área de interés especial es el manejo de la vía aérea, la seguridad del paciente, la educación médica, incluyendo la simulación a escala total, la neuroanestesia, el transporte internacional de pacientes y la anestesia oncológica. El doctor Huitink trabaja en varios hospitales y combina esto con múltiples actividades educativas y de consejo médico. En 2013, hoy es el director de la Airway Management Academy, que es una organización sin fines de lucro orientada al entrenamiento de todos los profesionales sanitarios en el manejo de la vía aérea. El objetivo de la Airway Management Academy es mejorar la seguridad global del paciente durante el manejo de la vía aérea. Es una red global de expertos en educación. Fue miembro del comité organizador del Congreso Mundial de Vía Aérea en 2019, que se hizo en Ámsterdam. En su trayectoria académica tiene múltiples publicaciones de gran relevancia, especialmente en temas de estrategia para el manejo de la vía aérea difícil. Entre ellos destaca el estudio llamado El Pequeño NAP4, al cual el doctor Tim Cook se refirió en nuestro webinario pasado. También publicó el ebook Intubación fibra óptica Vigil en 2021. Es también miembro del panel internacional de consejeros de la revista Anestesia. Y recientemente ha configurado la aplicación Triage de la vía aérea, que es una herramienta de estrategia para enfrentar el manejo de la vía aérea en cualquier paciente y circunstancia, basada en la aplicación de una lista de chequeo muy intuitiva, que se puede bajar al teléfono celular de manera gratuita. Está disponible en 10 idiomas. Me enorgullezco de haber contribuido en su traducción al español. Y creo que es una aplicación tremendamente útil, especialmente desde el punto de vista formativo y práctico. Por toda esta prolífica y generosa actividad educativa, el Dr. Huitink recibió en 2018 el Fellow de la EAMS, reservado para quienes han contribuido de manera significativa al desarrollo de estrategias que permitan mejorar la calidad y la seguridad del manejo de la vía aérea. Así que de esta manera voy a dejarles con ustedes al doctor Johannes Huitink. Él tiene lamentablemente un problema con la conexión a su archivo, así es que lo que voy a hacer es compartir la pantalla con un video.
Fue tan triste y entre medio yo y Benja con fiebre alta para nosotros 2 días.
Quiero que veamos las preguntas, Gabriela. Tenemos 2 preguntas antes de la charla del doctor Huitink. ¿Pueden mostrarlas? Aquí está la primera y la segunda, están las 2 juntas. Entonces veamos la primera, que dice, ¿qué cree usted que es la intubación híbrida? Que es el tema de hoy día del doctor Huitink. Hay 4 alternativas: el uso del videolaringoscopio más el buggy, la intubación a través de supraglótico, el uso de videolaringoscopio más un videolaringoscopio flexible, el uso de videolaringoscopio más intubación retrógrada. Pueden ustedes votar por esta primera pregunta. Para que podamos tener una idea acerca de lo que sabemos que es la intubación híbrida, que es un concepto nuevo, y el doctor Huitink nos va a ilustrar acerca de esto. Están configurando las respuestas. Y la otra pregunta es, ¿ha usado o hecho alguna intubación con videolaringoscopio flexible asistida por videolaringoscopio? Entonces, parece que tenemos ya las respuestas definitivas. Hay más personas votando. Yo creo que se dan los resultados. Aquí los tenemos. Los tenemos. La gran mayoría, Hans, dice que la intubación híbrida es el uso de videolaringoscopio más videolaringoscopio flexible. Otro porcentaje menor, el uso de videolaringoscopio más intubación retrógrada, y algunos pocos, el uso de laringoscopio con bully e intubación a través de supraglóticos. ¿Qué te parece, Hans? Esas respuestas. Estás silenciado, Hans. Ahora sí.
Yes, thank you very much, Ricardo, for the kind introduction. And I'm happy that many people already think that hybrid intubation has something to do with use of combined techniques, video laryngoscopy and flexible intubation. And I think it's an interesting presentation because many people say they don't use it. So maybe they can learn a lot today. And I'm looking forward to the questions afterwards and go into discussion with you about this rather new hybrid intubation technique. And welcome to all listeners from Chile and of course from all over the world. It's a truly international event. Thank you very much. I hope you enjoy my presentation. Thank you.
Estupendo. Vamos entonces con la presentación que afortunadamente el doctor Huitink logró, a ver, esto, no. Perdón, este es PowerPoint. Y esta es. Ok. Entonces voy a echarla a andar. La idea es que esta presentación está grabada por el doctor Huitink, porque en este momento él tiene un problema y afortunadamente nos mandó esta grabación, así que no podemos disfrutar esta presentación como si estuviera en vivo. El doctor Huitink nos acompañará en toda la sesión y después responderá las preguntas que ustedes quieran formularle. No sé si se ve la pantalla completa, Gabriela.
Sí, doctor, se ve.
La voy a echar a andar entonces.
Hello, everyone. This is Johannes from meetings.
No se escucha.
Ya, lo voy a empezar de nuevo.
Hello, everyone. This is Johannes from meetings.
No se escucha nada, doctor.
Voy a tener que detenerla. Perdón, Hans, no se escucha no hay sonido. Entonces, lo que yo sugiero
Yeah, Ricardo, when you tried it before, the sound was okay. Can you mute your microphone? Is that a problem?
no sé, yo silencié mi micrófono, pero no se escucha. No se escucha. Yo creo que lo que podemos hacer es echar a andar la presentación y hablas tú. La dejo sin sonido y hablas tú con las diapositivas. ¿Qué te parece?
Yeah, we'll try. But I think you have to mute your microphone and use your internal microphone because it's a recording. I think it's in your settings. I'm not sure.
Configuración. Micrófono integrado y que el sistema puede ser ahí. No lo sé. Veamos a ver si funciona esto. A ver.
Sound definition.
No, doctor, se escucha súper mal.
Y no escucho la traducción simultánea. No escucho la traducción simultánea tampoco.
If you start a presentation, Ricardo, if you just start a presentation, I will try to talk. You can just start it. Start anew. Yeah.
Sí. Sí. Voy a...
Yeah, just start from the beginning. That's fine. Okay, can you hear me?
No.
This is plan B, no problem. Okay. Welcome to the webinar. My name is Hans Huitink. I'm currently in Amsterdam and we have some technical problems, but it's not a problem because we are anesthetists and we can deal with that. I'm happy to talk to you in English and that translation will be in Portuguese and Spanish because my Spanish is not good enough. Ricardo, is the presentation running? It should be the next slide. Yeah. Because I don't see the screen moving to the next one. Did you start it?
Está iniciada.
Yeah.
Hablas un poco y se va a cambiar en algún momento a la primera diapositiva tuya.
Yes, okay, thank you. This is a talk about hybrid intubation, in Spanish, Intubación, Hibrida, and we'll discuss what this is, how we can use it, and what are the indications and contraindications. And there seems to be some time delay, but it's not a problem. If you are on Twitter, you can find me and the Twitter handle Airway Management Academy, and we share everything airway, and it's very interesting discussions, worldwide discussions with anesthetists and airway lovers. So try to follow me, and we can discuss topics during 24/7 during the day and night if you want. There seems to be a delay, so I speak more slowly. Next slide is coming up. Can you forward it, Ricardo? Because that. On my screen, the presentation has stopped. Yeah, I'm involved in airway research and then also airway courses. And as you can see, this is what an expert does. Play around with the airway gadgets, no more or less. And I think this is a nice presentation of my name, Hans. My formal name is Johannes. What is hybrid intubation? I talked about that to two other people, and I also asked this question on Twitter. And then Nicholas Grimes from Australia had a question, and he said we need to define it. And this slide should proceed now because there's a next one. And he asked me a question: is hybrid intubation the same as a combined technique, or FAVI, or FAVI with an F? And he said we really need to choose a term here, and I think he's right. And therefore, I tried to summarize the techniques and also make up a definition about what we mean when we talk about hybrid intubation. I talked also to other people, to Alan O'Sullivan from Dublin, and they actually don't have a definition for hybrid intubation. And I looked it up in Google. And if you find it in Google, they say, okay, it's a thing made by combining two different elements or a mixing of them. And of course, we know hybrid from the cars, hybrid cars with electricity and gasoline, but it is a combination of techniques. So that's what we mean with hybrid. If you try to find it in the literature, you can find an old article from 1995 with the title Hybrid Intubation Technique for the Management of Difficult Airway Case, but that was a combination of a light wand and a flexible scope. So that was actually one of the first articles talking about the definition of hybrid techniques. But if you look at more recent literature, you will find that most people mean hybrid intubation is a combination of a video laryngoscope and a flexible scope, or if you want to define it better, two techniques with the camera. This is a case of a hybrid nasal intubation technique for head and neck surgical patients. They had difficult cases and they made a nice review about the combination of techniques. And there's another presentation from Nedred et al., who combined the video laryngoscope and the fiber optic scope to do a difficult case. So this is my definition currently as we speak of hybrid intubation. It is an airway technique that combines video laryngoscopy with another optical device. So you can make all kinds of combinations. Most often we use a video laryngoscope and a flexible scope, and then we call it FAVI, video laryngoscopy assisted flexible intubation. And I'll give you some examples of it with some pictures so you know what I mean, and then we can decide what we're going to do and in which patients we're going to use it. And then we can, for example, use a King Vision video laryngoscope and the flexible disposable scope from Ambu. And as you can see on the screen of the video laryngoscope the insertion cord of the flexible scope. So actually you don't need the monitor screen of the flex scope. This is the King Vision combined with the A-scope Ambu Flex. And then there's more examples. I will show you more examples. And this is at the Glide Scope video laryngoscope. You can recognize the video laryngoscopy screen, and Olympus non-disposable scope. This is the black scope. And as you can see, you see the arytenoids. You introduce the flexible scope in the glottis, and you have a great overview over the larynx, in the larynx. And that's one of the big examples and big advantages of using combined techniques. You can see the surroundings. This is a King Vision again with another scope, and this is a CMAC D-blade, storage D-blade with Olympus flex scope. So you can make all kinds of combinations, and in the end, it doesn't matter which device you use, and it's dependent where you work and what is your experience. So many examples. If you use a channel blade, it's a bit easier because the tube is already in the channel of the video laryngoscope, and the only thing you have to do is use the flexible scope to finalize the last part of intubation and enter the trachea. So these were 4 or 5 examples of different techniques with different scopes, and are all called hybrid intubation or FAVI. Eleanor Sullivan from Dublin said FAVI is a very useful technique. This is also from Twitter. And she commented on an interesting case from another doctor, and they say, okay, this is very interesting. Let's use it more and more. And if people from Australia like Crimes and Professor Sullivan are using the technique, and you will see that Professor Tim Cook will use it in the next slide. They are teaching this to delegates of airway courses, and so if they use it and I use it, so you see that the experienced airway managers are trying to combine techniques to increase first pass success. This is Tim Cook teaching, I think, somewhere in England, and he has the A-scope, and I think it will look really well, the start CMAC video laryngoscope, and he's laughing, so I think the intubation was very successful. So this is what experts do, and this is what we can do if we combine techniques. So when we do it, it's good to have a recipe and learn how to do it. I've come up with some tips and some advice how we can do it. So look at the slide and see a stepwise approach. First, you insert the video laryngoscope and you look in the mouth and then at the screen. Step 1, to identify the vocal cords. And remember, don't aim for the best view. You need enough space in the larynx to maneuver the tip of the flexscope. Then you ask an assistant, so this is two-person technique, to hold the video laryngoscope exactly as I do. And actually anyone can do this. This is easy. You can ask a nurse or an assistant, because you expose the larynx and then they hold the video laryngoscope. Then you take the flexible scope and you introduce the scope in the mouth or the nose. I always start in the mouth because that's the easy part of the FAVI technique. So these are the first 5 steps of the hybrid intubation or FAVI technique. And then you have introduced the flexible scope in the mouth. You'll just use the flexible scope as an expensive bougie. Actually, that's what it is. You can maneuver the tip, you can flex the tip, and that's what you normally not can do with a bougie or something that is rigid. And now we wait for the next slide, and we will go to step 6. And there's a time delay in the slide, so we're waiting for the connection between Chile and Amsterdam. It's not a problem. And step 6 would be that you introduce the scope into the trachea. And then you can actually see on the screen that you had a successful intubation. Ricardo, could you please press something that we can see the next slide? There seems to be a delay. Yeah, yeah, thank you very much. I can't see the next slide. There we are, thank you. And remember, don't look at the monitor screen of the flexscope. You actually don't need it. You maneuver the tip of the flexscope into the trachea. Then you verify correct flexscope position. Step 9, you railroad the tracheal tube and intubate. And then you inflate the cuff, retract the flexscope and the VL. I will explain in a different way in the next slide why I think this is a very useful technique and why this is not actually very, very difficult to do. You need to train it. You can do it on a mannequin. You need to practice this. But if you understand why this works better, now we go backwards. Yeah, then go forward, Ricardo. Then I can explain why this technique works easily in most patients. I think we need to forward 1 more minute and then I can proceed it. Yeah. Thank you very much. Okay, we'll give it a little bit of time. So why is this not so difficult to learn airway rescue technique? That is because we can see surroundings, and actually you have 2 monitors. For example, if you have a patient with a bleeding blood in the airway and you can't see anything on the video laryngoscope, you can use the monitor of the flexscope. This is an aircraft carrier. And you think, why do I show an aircraft carrier? Because we can land planes. So I can't, the pilots can. And there are actually, if you play a computer game and try to land a fighter jet on the aircraft carrier, it is difficult to land because this is what you see. You're the pilot, you're in the cockpit, and this is what the flexible scope can see. This is your flexible scope. And the flexible scope is going to land on the aircraft carrier. And it's difficult to see surroundings. You see a target and you have to land on the ship and that's it. But actually, it's much easier if you use the chase plane view. And you can do that in a computer game. Maybe you've done it with race cars or flying planes. And if you look from behind, you can steer the plane to the aircraft carrier, which is easy to do. You can see I can turn aircraft carrier into vocal cords. Easy to do. And now we're going to fly through the vocal cord with the plane. So this is the view through the flexible scope. This is what a pilot can see from the cockpit. We need to maneuver the flexible scope through the vocal cords. And this is your target. This is what we see with the flexible scope. You see the vocal cords and you see the trachea. But now if we combine this technique with a video laryngoscope, I can see mountains, I can see surroundings, I can see the whole plane, I can see the whole picture. And everybody can put a stick in a hole, if you know what I mean. This is your flex scope. This is a plane. This is your flex scope. And we are going to fly with the flex scope through the airway, through the larynx, and do airway management in a different way. We can steer the flex scope from behind. This is what we see. We can see the plane from behind. We can see the flexible scope from behind. And that way we can easily maneuver the plane or the flex scope into our target, to the target, which is the trachea and the glottis. And this is actually called chase plane view. You can look from behind. This is what we do. We have the video rolling the scope, and here is the flexible scope coming. You can steer it right into the trachea and fly into the lungs. This is why it is not so difficult. This is a perfect combination of two techniques. So remember, two techniques. You need the video laryngoscope, the screen of the video laryngoscope, but not the screen of the flex scope. It's easy. Flexible scope goes in, thumbs goes down, thumbs goes up, and that's actually the movement you need to make. And you can check and verify correct tracheal position. Of course, on the second screen, if you have two screens, it's always better than one. But do that afterwards when you want to verify correct intertracheal position. And remember, the flex scope, I said it before, is just an expensive bougie. No more, no less. And if you are in a hurry, and I think the WAVI technique is a great airway rescue technique, you don't even have to connect the flex scope to a monitor. It's just an expensive bougie. You can flex the tip, the VL is on, you give it to an assistant, and you intubate the trachea. Practice this on a mannequin, and you will find out that it is really easy. I do this with students. When I teach airway classes, I do this with nurses, I do this to trainee anesthetists, just to let them know that even if you're not really experienced, and most of us are not really experienced intubated with flexible scopes, you can turn your flexible scope into a very powerful tool, because everyone can move in the flex scope in this way. What are the indications? The indications are airway rescue, maybe bloody airways, not when it's breathing profusely, but if there's some blood in the airway, you have two devices and two monitor screens, which is fine. If you have time pressure, you don't have to connect things to monitors, you can just start. It works really well in morbidly obese patients. I've rescued, I think, 2 or 3 patients in the ICU when I was called to come to help after accidental detubation. And for example, if you have limited access to the patient, for example, entrapment in a vehicle or in some kind of building, it's a good technique to do face-to-face. And I will show you an example of a case of a patient who was in a halo frame, and she had a fractured neck, and she was put electively on the operating room schedule because they had to do fixation. She was perfectly stable. And the idea we had was to intubate this patient with a video laryngoscope, but then we found out that we couldn't lift the epiglottis, and then we tried to do a WAVI. I have included a video of this procedure into this presentation. I think this will load really slowly, so you can see all the steps we're doing, and the next slide will probably be the start of this video. And then I will talk you through the video and see what's happening, and so you really can understand how you can do this. And if you pre-oxygenate your patient really well, you have time to do this. So if the oxygenation is not a problem and saturation is okay, you can take time to do all the steps. And if you practice the 10 steps, it's not difficult to do. I will just wait for the video to start. This is the case. This is on a mannequin, but this is the halo frame she had on the neck. So you see, you cannot move the head. This is an advanced complex airway. And this is why you use advanced techniques. And we thought, okay, we can backmask ventilate, so she's in a very stable position. Just try to do the video laryngoscope, the CMAC. And if that's not working, we have the D-blade. And most of these patients can be intubated with these techniques. We took the time, and this was the best view we got with the tip of the D-blade in the molecular. And as you can see, you can recognize the epiglottis. You can recognize, if you know that it is a D blade, the blade. But what we tried, what we did, we couldn't maneuver the blade into the larynx, and we pressed on the neck. We did bimanual, we did manipulation with 2 hands, by manual manipulation of the neck to get a better exposure. And all we got was this view. And then you have a problem, because how to intubate this patient if you try a bougie in the situation, you can't even see the glottis, you can't even see the arytenoids. You will not be successful because you cannot make a curve. The video should start now. And then I'll guide you through this intubation process. Can you forward a little bit, Ricardo, maybe? Because the video normally starts. Yeah. Thank you. Yes, thanks. There we go. This is the first attempt with the flexible scope. As you can see, the D blade is still in position. This is the best view we got. I would say this is a percentage of glottic opening of 0%, or comic and Lehane grade, I don't know, 3, 4. You don't see anything. And now what I tell my trainee anesthetists, okay, get the flexible scope, put it in the mouth, and try to find the insertion cord of the flexible scope in the monitor screen of the CMAC. This is actually the image you see on the CMAC monitor. So this is the image on the video laryngoscope. And now we can see the scope coming from the right. Here it is. And you can see that the scope has to be introduced over the arytenoids, but below the epiglottis. And because there is not much space in the larynx, she has a little bit of problems because the scope is pushed away because of the anatomical structures. But the idea is to find the glottis and introduce a scope. This was actually a second-year anesthesia trainee, had never used a flexible scope, and I was guiding and standing behind her, and the patient was very well oxygenated, so we had time, we had minutes of time, and I just asked her, okay, try to introduce the flexible scope into the glottis. In this patient, I would use the second screen, because the image on the video laryngoscope screen is rather bad. The image quality is okay, but you can't see the glottis. So in this patient, the hybrid intubation will help us. We do the intubation, the first one with the VL screen. And then when we enter the trachea, we have a quick look. And now she's trying to move the tip of the scope over the arytenoids. And it's slippery. So this is a real intubation. And then she managed to enter the trachea and enter the celiac arena, and then you double check this on the monitor screen with the flex scope, and then you advance the tracheal tube, and the patient is intubated. Normally, if you have a slightly better view of the video laryngoscope and get a better view of the glottis, you will recognize the arytenoids. You say maybe 10 or 20 or 30 or 50% of the glottic opening, and then you can verify with the team that your flexible scope is really entering the glottis, and then you will have a successful intubation. Now you see the tube is coming. This is the tracheal tube entering the trachea. Then the flexible scope is retracted and removed, and you can check capnogram or the monitor screen of the flex scope, and you have a successful intubation. This took, I think, 3 minutes, maybe a little bit more. And you can take your time. But then if you're in a hurry, don't connect the flexible scope, and in most patients you'll see more of the glottis. Are there any contraindications? I don't think so. Maybe the mouth opening is not big enough to insert the video laryngoscope. If you cannot introduce the blade, then you will have a problem. You can't use the technique. But even bleeding or time stress or anatomical problems or maybe physiology, I think this technique can be used in almost all advanced complex airways. And this is great because if you know how to use this combination of techniques, you can almost intubate every patient you will encounter on your career or in your medical pathway. I think that's why airway experts use these techniques a lot now. Which video laryngoscopy blade should we use? Channel or unchanneled? Hyperangulator or Macintosh style? It doesn't really matter. You can find out for yourself what works well in your patients and what kind of equipment you use, depending on the country you work and the hospital you work in. And remember that you need a little bit of space in the larynx. So I always try to use a narrow blade and not a big one, not a bulky one, because if you enter the glottis or enter the larynx, you need some space to maneuver and you need some room in the larynx to maneuver the tip of the scope. And remember, it looks easy, but you need to train this in the simulation lab. You need to train this with the team so you know the 10 steps. And if you want to train this, just take my presentation. And I can also put this on Twitter if you like. If you have the 10 steps, you can do the 10 steps with your team, and this will guide you through the intubation process. And if you have an assistant helping you, it's always the best practice to ask that person to step to the left side. You intubate with your left hand and you stand, then pass over the video laryngoscope to your assistant. You move to the right side and he or she stays on the left side and just holds the video laryngoscope exactly as you do, so you can see part of the glottis. And then you will maneuver with the flexible scope with your right hand. I've tried to do it with my two own hands. It's not possible. So if you hold the video laryngoscope yourself and the flex scope yourself, you need to be really lucky. God made one mistake when humans were created. He should have given us 3 arms and 3 hands, because sometimes we need an extra hand for intubation. That would be very practical. It's maybe 1,000 years or 10,000 million years from now, we evaluate 2 persons with 3 arms, which would be great for intubation. So you need an assistant. Is it difficult to learn? No. Is a prior experience needed with flexible intubation? I don't really think so. As said, I practice this with medical students and nurse anesthetists. They like it, they love it. Is it more expensive? Yes, it is, because you need to have the resources to use a flexible scope. But again, you don't need a monitor. So if you have some disposable scopes in your operating room or intensive care or emergency room, you can try it without a monitor. And when there is time pressure, remember human factors come into play. You can practice this in simulated scenarios really well, because you can make mistakes. So even if this looks normal to you, even if you think what you do, you need to practice this. And this is actually true for all kinds of airway management techniques. And remember the aircraft carrier, remember the plane. So if you use a flexible scope, you are sitting in the cockpit of the pilot or of the plane. You don't have a surround view. Step out of the plane, go into the chase plane, fly from behind, and you will be able to steer that plane, your flexible scope, through the larynx as an expert pilot. Okay, the next slide, please. Let me see. I think it's in summertime in Chile now. It's getting slow. Yeah, the problem. Okay, then almost the last slide. We can also combine multiple techniques, and of course, we make a step further. And what you see here is a combination of hypernasal oxygen, a Kingvision video laryngoscope, the iris infrared intubation light, and the tri-tube, very small tube with a vent-train oxygenation ventilation device. So maybe we can call this hybrid plus and do it in the next webinar. So I think for now we keep it in hybrid intubation, which is a combination of techniques with 2 cameras, a dual camera technique. And if we move on, maybe we use a robot or we use hybrid plus, and of course we play around a lot with airway stuff, and that's I think one of the most interesting aspects of our job. It's a way you can do, and we don't really need this, but in selected patients, experts can do this at their centers. I think if you ask me if hybrid intubation is valuable for our practice, I think yes. And this is the conclusion. Hybrid intubation can be a very useful technique for your clinical practice. It has a higher first pass success rate in advanced airways with complexity. It is very useful in bloody airways because one of the screens will most probably have a view. It is a great technique for airway rescue, and it's very good for team situational awareness because you've got two screens, the team will help you, you're not alone, and this will improve your clinical practice. So the conclusion of my talk is hybrid intubation can be a very, very useful technique for your clinical practice. I think you should try it. Don't be afraid to do it. It is not difficult, and you could even practice this in your normal daily practice. And if you know how to introduce a bougie, you'll probably know how to use a flexible. One of the last slides is coming up next. Almost there. Thank you. I would like to give attention to next year already. We will organize a big airway teaching festival, the Amsterdam Airway Festival, in June, 10 to 17 June 2023 at the Olympic Stadium, which is our Airway Management Academy teaching location. And we will organize multiple airway courses, so you're more than welcome to join us. And this will be a kind of festival with music, with food, and courses every day. And you could run courses for 6 days if you want. So I would like to invite you to Amsterdam, and the weather will be great in June. And so it's a great opportunity to visit our great city. Sorry for the technical difficulties. I couldn't access my desktop with Zoom. I couldn't access it with a password, and then the video connection is slow, but I think our plan B or C or D worked really well. I'm really happy to answer any questions. Thank you for your attention. Thank you, Ricardo. I think there's one more slide. Yes, there it is. Muchas gracias. Thank you very much. And this was my Christmas tree. This is my Christmas tree. So yes, you can see all kinds of airway stuff in the tree. And I had to take it down after half a day because my wife didn't like it, but I thought it was really funny. Thank you. Thank you. To answer any questions. I hope you could understand it and the English was not too fast. And I liked my presentation. Thank you.
Voy a dejar de compartir entonces, Hans. Te damos las gracias por esta brillante exposición acerca de este concepto nuevo, que tal como tú lo expresaste muy bien, representa una estrategia de un doble chequeo de imagen. Esa es la idea fundamental detrás de esto, que haya un doble chequeo de imagen que nos permita obtener un éxito de intubación en aquellos pacientes que puedan ser difíciles de intubar cuando uno tiene solamente una sola perspectiva de imagen para poder lograrlo. Entonces yo quiero invitar ahora a los participantes a que hagan preguntas en el chat, o si no, levanten la mano, y quisiera pasar también a las preguntas después de la charla. Gabriela, si nos las puede mostrar. Ahí tenemos las preguntas después de la charla, y la primera es: ¿cree usted que la combinación de dos técnicas lleguen a ser el estándar? Pregunta interesante, porque ya vemos que el doble chequeo de imagen puede contribuir significativamente a mejorar nuestra eficacia en lograr la intubación traqueal de aquellos pacientes posiblemente que se anticipe una dificultad importante en cuanto al acceso o la visualización de las estructuras glóticas. Y la otra es: ¿cuál es su técnica preferida de intubación híbrida? Esta respuesta la vamos a ver en el chat, o pidiendo la palabra si quiere. Les solicito que ustedes pidan la palabra o levantando la mano o haciendo algún comentario en el chat. Entonces dice que un 63% creen que estas técnicas combinadas no van a llegar a ser el estándar. Un 70% cree que solamente basta con una sola técnica para ser considerada como estándar, que las técnicas combinadas probablemente sean de excepción. Eso es lo que entiendo yo. No sé si Hans tienes algún comentario acerca de esta respuesta.
Yes, I think I agree that this will not become the standard, but for selected cases, it will be the standard. And I would like to mention, as you did before, airway triage app to triage airways. I think basic airways can actually be managed with basic techniques. You will never need to use a hybrid technique for a patient with a basic airway. You can do that with a back mask or LMA or whatever technique you like. But if you have an advanced airway with high complexity, and then, I mean, anatomical complexity and or physiology complexity, there may be a select group of patients where you always should start with this hybrid intubation technique. And I think for about very obese patients, bleeding patients, or patients where you only have one chance for rescue, for example, an accidental intubation in the ICU, this could become a standard practice. And I must say, if they call me for help, depending on the hospital where I work, I always like to start with a dual technique, because I know there are two screens or two devices, and I know how to do this, and it gives me more reassurance that my first pass success will be greater than just with one technique. So I think the answer is, it is, I think, a very valuable technique for a select group of patients, and of course we need to do studies to find out which patients, but I think you could start with airway triage app. If you triage the airways and summarize complexity factors, you could choose to start with a hybrid technique if you have a lot of complexity factors, and also complexity factors in multiple domains. So not only anatomical, but also in other domains like location, where am I, or physiology, or time pressure. Yeah. And I think it's too expensive to use it in all patients. It's really not needed.
Perfectamente. Antes de pasar a algunas otras preguntas, perdón. Hay unos comentarios del doctor Juan Carlos Mandujano que nos dice: muchas felicitaciones, Hans. Creo que es una técnica interesante, sin embargo me parece que la principal dificultad técnica a la que nos pudiéramos enfrentar es la disponibilidad de los dos sistemas ópticos. Es decir, claro, aquí en Latinoamérica tenemos el problema de la dificultad en el acceso a los dispositivos más complejos. También dice que cree que si mantenemos el concepto de híbrido como la combinación de técnicas, es muy probable que sí se vuelva el estándar de abordaje de vía aérea, que se mantiene el concepto. Nosotros, por ejemplo, dice en México, hemos utilizado la intubación con fibroscopio a través de supraglóticos, que ahí también podría ser una suerte de técnica híbrida, pero no utiliza el concepto de doble imagen, que es el que está detrás de este concepto de intubación híbrida, doble imagen. Dice, para dejar colocada una guía de intubación retrógrada. Claro, exactamente. Marcelo Ramos, desde Brasil, te pregunta que si usas esta técnica híbrida en casos con pacientes despiertos y también en pacientes dormidos. ¿Qué es acerca de la intubación? Volumen, además.
Yeah, happy to comment on that, Ricardo. Regarding the first question, then I totally agree. If you combine techniques with LMAs, or you go with a flexible through the LMA, or even some bougies and other devices, you could call this hybrid, but there are so many options. And I've written an editorial on anesthesia and calculated all the oxygenation options for one single patient. If you change everything once in a single patient, you have more than 1 million ways to oxygenate in a patient, really 1 million ways. And if we would call all these combination hybrid, you don't know what you mean. So we need to make a definition. I think it's easiest to call hybrid intubation a technique with two cameras, dual camera technique. And all the other techniques, I would just say it's a combined airway management technique. And of course, I agree, you need to have resources, and many countries can't allow to use two optical devices. And I totally know that's a problem. And then you need to be inventive. And for example, use the video endoscope if you have one. And there are also bougies with a flexible tip. So maybe you don't need a flexible scope, but use a flexible tip bougie. And be creative. The combination of airway techniques is often very powerful. But I think we should define hybrid as a dual camera technique to make it clear from what other combinations can do. And then the second question, yes, you can do it in awake patients, and I've done that. And if you think you may encounter anatomical really difficult airways, for example, tracheal stenosis or anatomical anterior larynx or T4 supralacrotic airway tumors, you can topicalize the airway, introduce a video endoscope, and it's easiest with the channel scope sometimes, but not in all patients. And then you can do a FAVI in an awake patient. Yes, it's a valuable option. Often it's face-to-face because the patient is sitting upright, but yes, you can do it in a awake patient, no problem. Yeah.
Perfecto. Perdona, ¿qué crees tú acerca de la pregunta de Marcelo Ramos de Brasil? Si usas la técnica híbrida para casos, para pacientes despiertos y pacientes dormidos. ¿Hay alguna diferencia en relación a eso? ¿Alguna consideración especial? ¿O solamente es para casos de pacientes despiertos con ventilación espontánea?
Yeah, I think if you know you can oxygenate, for example, with high flow nasal oxygen, 30 or 60 liters per minute, you can easily do this asleep. But if you are worried about anatomical changes because of tumors or edema, then of course it will be easier to do this in an awake patient. So it's difficult to answer. There is a difference between asleep and awake. I found that the cases where I used FAVI were often airway rescue cases. And these patients will probably be already asleep, or they were asleep and the tube fell out, or they come in very sick, or sepsis or trauma. So I think the hybrid technique was developed actually during airway rescue situations. But yes, there is a problem. Again, you can use the technique in both types of patients, asleep and awake. And I think the high flow nasal oxygen, the OptiFlow Thrive situation, has given us many opportunities to oxygenate patients throughout the procedure. So then even if it takes a bit longer, your patient will not desaturate. So the combination, and it's the last slide you saw with the Iris and all the equipment, Hybrid Plus, it's a great thing. Start with good assessment, do a perfect peri-oxygenation technique like high flow nasal oxygen, start with a video endoscope and use a flexible scope to bail you out or to find a way. So that's another powerful combination of existing techniques. Yes.
Perfectamente. Mira, te quería preguntar, ¿cuáles crees tú que podrían ser las indicaciones para usar una técnica híbrida? ¿En qué pacientes estaría indicado?
Yeah, I think if you select cases, I would maybe say in the really obese patients, like BMI over 50 or 60, that's a powerful combination to do, because you know the tongue will be large, oxygenation is problematic, so your first pass of success will be higher if you use a combination. So extreme obesity is a good combination. Again, if you think that you only have one chance of intubation because the patient is so sick or the airway is so difficult, then I would start with two devices. Yeah? So maybe you don't have to use it, but you're prepared to do it. And I've done several cases with bleeding in the airway, and sometimes it's only bleeding on one side. And if you're lucky, you will have a good view on one of the monitors you use, but then you use two devices connected to monitor screens. So I would say extreme obesity, I would say airway rescue, I would say blood in the airway. Those are good indications. And there will probably more indications, but it's a select group of patients. Yeah. it will make your life easier. And if you become really good at it, and if your hospital has the resources, it's easy if you can grab the double intubation trolley and use a scope. But I know it's expensive sometimes, and if you don't have reusable scopes, you don't get all these disposable scopes again. One single use for training purpose. So you should practice this in a mannequin in the simulation lab if you can. Maybe there are more options, I don't know, but this is, I think, the three very good groups to do it. I've used an oral hybrid intubation technique. I didn't mention this, but when the Vivasite camera tubes came on the market, and that's also one of the questions in the chat I saw. And the question is, do you use hybrid for double lumen tubes? And what I've done is you can easily use a video laryngoscope for glottic exposure, and then, for example, use a double lumen camera tube for intubation. That's also dual camera technique. I think that's one of the other options of a hybrid technique. So use the video laryngoscope to place the double lumen tube, which is sometimes difficult, and then move on to the monitor screen of the camera double lumen tube. That's a great technique for double lumen tube intubations for VAVI, because normally you only have the flexible scope in the double lumen tube, and yes, you can do that as well, but then you need an extra hand. I think you need 4 hands to do it. You can do it, but it's we need more help. I only have 2 hands.
Hans, me llama la atención, me llama la atención esto de la utilidad de esta técnica de doble imagen en vías aéreas inundadas, vías aéreas con sangre, con secreciones, porque normalmente uno consideraba como contraindicación del uso de dispositivos con imágenes cuando la vía aérea estaba inundada o tenía sangre, por ejemplo. Y ahora tú estás diciendo que no, que posiblemente es una indicación de la técnica híbrida pudiera ser útil cuando la vía aérea está inundada. Eso nos podría a lo mejor ilustrar un poco más del...
Yeah, it will not replace suction. So if there's vomit, or if there's saliva, or is there edema or blood, you also need very good suction. But you could use a salad technique like suction. What's the suction? I forget salad. Suction-assisted laryngoscopy and decontamination. So if you introduce a laryngoscope, you start suctioning, then you park your decanter catheter or whatever catheter you use to the left of the laryngoscope. You continue suctioning, and then you keep the flexible scope. You can intubate. But so if the airway is flooded, you need suction as well. And it is really flooded with blood. Of course, there's 2 imaging technique with the blood image, red image, then you have a problem. And then I would choose to go through a conduit like an LMA, like an eye gel, because sometimes you may be lucky to introduce the eye gel, place it on the glottis, the blood will go outside the supraglottic airway, and the conduit will be clean for the flexible scope. But then I wouldn't call it hybrid intubations. I think it's a combined airway technique. But again, I think in the literature, there's no clear definition. So whatever definition you use for hybrid is fine up till now. I've come up with this definition. I think it's understandable. So hybrid intubation used the dual camera technique, the bone freeze or flexible scope or video laryngoscope or a double lumen camera tube, but you need 2 cameras. Yeah.
Mira, Mauricio Malito desde Brasil, ¿lo conoces, Mauricio?
Hey, Mauricio. How are you?
Te manda saludos, felicitaciones, dice, excelente presentación. Y te pregunta, ¿cuál crees que es la mejor manera de entrenarse en esta técnica híbrida? Primero dice entrenar la parte fibroscópica y la parte videolaringoscópica separadas para ganar experiencia, y solamente después de eso ir a la híbrida, o también podría ser la híbrida en un único momento, podría ayudar a que el otro dispositivo fuera también más fácilmente aprendido. ¿Cuál te parece que es la mejor manera de entrenarse en esta técnica híbrida? ¿Por separado o junto?
Thank you for your question, Mauricio, and it's a good question. And I started hybrid, and it's not difficult to do. So you need a mannequin, you need a video laryngoscope, for example, CMAC or the gyroscope. And what I do is I show it once. I use the 10-step method I publish, and I can also show my presentation on Vimeo. We have an own airway teaching website, so you can access my video and see the presentation again. You do the 10 steps. And I do it with one assistant, and then I ask the patients in the workshop to do it like me. And actually, this is not a flexible intubation technique, because yesterday we taught that, and it's a 6-hour course. It's complex. You need to do things about topicalization and scope use and manipulation, and how to teach how to intubate patients awake. Actually, this is just the use of a flexible scope like a bougie, and you maneuver the tip. So I wouldn't make it too complex, because others will not repeat it, because then it looks too difficult. And actually, it is not difficult. If you know how to introduce a video laryngoscope and get a view, then you just show them how easy, relatively easy it can be to introduce a flexible scope. And this is great, because if you would do a survey and ask anesthesiologists, how many of you can do an awake flexible intubation? I think maybe 5% or even less will say, okay, I'll do this frequently. I'm really good at it. And most of us, most colleagues will do it once in a month or once a year, or have never done it. But if you make it too complicated, they will stay away from this life-saving rescue technique. And actually, this is not a difficult technique to learn. This is just a scope, and you don't even have to use the monitor. So I want to show this to all of us. And even if you've never used a flexible scope, if it's 4 o'clock at night and they call you for help and your patient is almost dying because the tube has fallen out, you can use this technique. So I would start simple with a mannequin and a video laryngoscope and a flexible scope, and don't connect it to the monitor screen. Just ask the students to maneuver the flexible scope into the glottis. And one thing that really helps is don't aim for the best view. If you have a great view of the glottis, if you see 100% of the vocal cords, you will have difficulties introducing the flexible scope, because the camera of the tip of the blade is already in the glottis. And if you look at the width of the blade and the glottis space you have in the larynx, there's not enough space. So if you recognize vocal cords, and if you're happy, move back with the video laryngoscope. So you do not improve your view, but you go backwards. And in that situation, you make more room for your flexible scope to enter the glottis. So to answer your question, keep it simple, try and train on a mannequin, and do not make it 2 modules. Just teach them how to use a video laryngoscope. And if you know how to get a view, and most of us can do this with a hyperangulated blade without intubation, and then show them how to introduce a flexible scope, and thumbs up, thumbs down, and that's it. And if you cannot get access via the mouth, you can also do the nasal approach. So put the scope through the nose. And in my opinion, most of us will manage that. So I think that's my answer to your question. It's no rocket science.
Gracias, Hans. Gracias, Mauricio. Gracias, Marcelo. Gracias, Juan Carlos. Los invitamos a seguir haciendo preguntas o comentarios. A lo mejor darle la palabra al doctor Ricardo Latrop. Hans, te presento al doctor Ricardo Latrop. Él es el director del programa de Anestesiología y tenemos una importantísima también asistencia de docentes y residentes de nuestro programa en esta sesión. Así que le doy la palabra al doctor Latrop.
Bueno, buenos días a todos, especialmente al doctor Hans, que sería buenas tardes para él en este caso, y además desearle un bonito fin de semana. En nombre de la Universidad, de la Facultad de Medicina, doctor, y obviamente del programa de anestesia y de nuestro Comité de Desarrollo Académico, muchísimas gracias por su exposición. unas felicitaciones, ha sido tremendamente interesante. Y la verdad de las cosas es que solamente quiero, fuera de agradecerle, hacer un par de comentarios con relación a su exposición. Como usted lo dijo inicialmente, esto es como el uso de un video laringo con imagen y un buggy caro. La verdad es que cuando uno hace una intubación combinada en esa situación, muchas veces uno adivina dónde está la glotis con el buggy y muchas veces tiene suerte y siente el paso a través de los cartílagos traqueales. El introducir en vez de un buggy un fibroscopio con imagen genera evidentemente una situación muchísimo más segura, muchísimo más fácil en el contexto de asegurar la vía aérea del paciente. En ese sentido, creo que la idea que ustedes tuvieron de usar una doble cámara, la verdad es que la encuentro tan genial como simple. Por lo tanto, creo que es un aporte tremendo para todos nosotros y los médicos que enseñamos anestesiología o los residentes que están en la etapa de aprendizaje, conocer la posibilidad de todas estas combinaciones. Y finalmente me voy a quedar con que evidentemente esto no va a ser el estándar de una intubación básica, una intubación habitual, sin predictores de vía aérea. Yo entiendo que este proceso, que puede ser caro al unir doble imagen con instrumental, que a veces es complejo en Latinoamérica tener disponibilidad, evidentemente va a estar circunscrito a pacientes muy complejos, a pacientes de intubaciones con predictores muy malos. Por lo tanto, creo que es un aporte tremendo en el sentido de la idea, y como todas las ideas geniales, son simples. Así que yo quería darle las gracias por estar con nosotros, por acompañarnos, por su invitación este otro año a Ámsterdam, linda ciudad. Y la verdad es que en nombre de la universidad y del grupo anestesiológico de la Facultad de Medicina y de la Dirección de Posgrado, muchísimas gracias por estar con nosotros y por haber hecho esta presentación excelente, con un gran aporte de ideas. Muchísimas gracias, doctor. Un gusto saludarlo.
Thank you for your kind words. It's really a pleasure to exchange ideas, actually what we do. And actually, I was in Peru 4 weeks ago teaching, and I know about the South American situation, but I also teach in Australia and in Europe, and we all have the same problem with the same patients, deoxygenation and intubation problems. We can all solve this in our own way in the hospitals where we work with the teams we have and the resources we have. I think the exchange of ideas is giving you other ideas and it will improve your patient work. So thank you again for inviting me, and happy to come back in the next session. And again, I will share all my videos free online on the Vimeo Air Management Academy website. So you can watch everything we do. It's format, so everybody can share. Thank you. Gracias.
Gracias, Hans. Ya compartía todo la descripción de tu sitio web para que puedan ver los videos que son todos puestos de manera abierta, de acceso libre en página web airwaymanagementacademy.com. Así, gracias, Hans. Yo quiero comenzar a despedir la presentación. Ya. Perfecto. Quiero en este momento empezar a despedir la presentación, mostrándoles la programación del próximo año, 2023, donde vamos a tener esta nueva constelación de expertos traídos de muchas partes del mundo. Voy a tratar de empezar en orden, desde izquierda a derecha, con el doctor Imran Ahmad, del Reino Unido. Él es el actual presidente de la DAS y que nos va a deleitar el próximo año. En segundo lugar, el doctor Paul Baker, de Nueva Zelanda. Él es el actual presidente de la Sociedad Americana, la SAM. La doctora Paula Chiesa, de Argentina. El doctor Javier Márquez, de Venezuela. El doctor Daniel Perín, de Brasil. El doctor Camilo Pizarro, que es probablemente un no anestesiólogo, pero intensivista, con una relevancia muy importante en el área de las unidades críticas en Colombia. El doctor Raúl Quirino, de Brasil. La doctora Laura Reviriego, de España. La doctora Claudia Sáenz, de Bolivia. Quiero darle las gracias a la doctora Sáenz por su gentileza y nos honra con su presencia el próximo año. También el doctor John Sackles, también no anestesiólogo, él es emergenciólogo de Estados Unidos, también perteneciente a la SAM, y nos va el próximo año a traer una charla muy importante. El doctor Tolga Sarakoglu, que es el actual vicepresidente de la EAMS de Turquía, que probablemente va a ser el nuevo presidente de la EAMS. Y finalmente el doctor Ashutosh Wali, también de Estados Unidos, de la SAM, que él es uno de los grandes expertos en el manejo de la vía aérea obstétrica, tema que todavía no hemos tocado en este webinario. Así que ustedes aquí pueden ver el programa el próximo año, el 28 de enero, la doctora Chiesa va a hablar de habilidades no técnicas en el manejo de la vía aérea. El 25 de febrero, el doctor Ahmad sobre las guías DAS para la intubación vigil, vía endoscópica. El 25 de marzo, el doctor Daniel Perín con el manejo del paciente con tumor cervical. El 29 de abril, el doctor Sarakoglu con la cánula nasal de alto flujo, las aplicaciones en anestesia, intubación y extubación. Y el 27 de mayo, el doctor Paul Baker nos va a hablar sobre el manejo de la vía aérea difícil pediátrica. El 24 de julio, la doctora Riviriego, un tema muy interesante que es cómo enseñar la intubación con videoendoscopía flexible. Eso para nosotros es muy importante, dado el carácter de académico que tienen nuestros centros, y muchos de ustedes también tienen esa perspectiva. El 29 de julio, el doctor justamente va a hablar sobre el manejo de la vía aérea en unidades críticas. El doctor John Sackles sobre la vía aérea. Uno de doctor Javier Márquez nos va a hablar sobre consideraciones de la vía aérea. El 28 de octubre, el doctor Wally sobre el manejo de la vía eléctrica. El 25 de octubre, Science sobre actualización en predictores de vía aérea difícil. Y finalmente en diciembre, antes de Navidad, el doctor Quirino, manejo de la vía aérea en el paciente obeso. Así que como ustedes pueden ver, vamos a tener el próximo año una diversidad de temas muy interesantes por muchos expertos internacionales. Así que los invitamos desde ya y les agradeceremos que difundan esta información entre sus contactos. La gran novedad que vamos a tener para el próximo año es que vamos a ofrecer certificación de asistencia a este webinario, para lo cual ustedes van a necesitar inscribirse en un formulario que vamos a dejar dispuesto online y que les vamos a notificar oportunamente el acceso a este formulario para que ustedes puedan inscribirse y obtener así la certificación de asistencia a este webinario. Finalmente, no me resta más que desearles una feliz Navidad y que el próximo año nuevo 2023 nos traiga a todos puras bendiciones, muchas cosas buenas y más vía aérea, por supuesto, para poder seguir mejorando nuestras competencias y así ofrecerles un manejo de calidad y seguridad a nuestros pacientes. Muchísimas gracias a todos.
Gracias, Ricardo. Gracias, amigo.
Paramos de grabar, Gabrielita.